Thank you to the committee for allowing us to present our data today on a new treatment of overactive bladder injection paradigm for peritrigonal injection of Onabotulinumtoxin, which is associated with a lower incidence of clean intermittent catheterization. These are our disclosures. In previous phase 3 and 4 clinical trials in patients with overactive bladder, Onabotulinumtoxin significantly reduced urgent incontinence and improved quality of life versus placebo. The previous injection paradigm was 20 evenly spaced intradetrusor injections, avoiding the trigone, which was associated with a relatively low incidence of intermittent catheterization versus placebo. The studies were pooled to increase the sample size, and the CIC rate was 6.2%. This study tested the hypothesis that by injecting into the trigone and peritrigonal region, we could maintain efficacy and improve quality of life while lowering the CIC incidence versus the standard injection paradigm. This is the study design. As you can see from the pictorial, 2 injections were into the trigone directly, and 8 were into the lower portion of the bladder, or the peritrigonal area. These were 0.5 ml injections for 10 total injections. Baseline demographics are in this chart below, and I will point out that these were primarily female patients. I want to say about 94% in the active injection arm and 100% in the placebo arm. So a very small percent of male patients. In all parameters tested starting at week 1, the new injection paradigm showed statistically significant improvement over placebo. As you can see, both urgent incontinence episodes from week 1 and maintained through the 12-week marks. More patients who received the alternative injection paradigm had a 100% reduction in urgent incontinence, again at all time frames, as well as greater than 50% reduction in urgent incontinence episodes versus placebo at all designated time frames. CIC use in the first treatment cycle was significantly lower with the alternative, starting with a relatively low 6.2%, and with the new injection paradigm, we're able to drop it to 2.6%. Of importance, if you can see, there's 2 patients who ended up doing intermittent catheterization with the new injection paradigm, and these were both in male patients with a history of BPH. So there were 0 female patients of the 73 who required CIC. So there were, again, none on this arm. Patients who received the alternative Onabotulinumtoxin injection had significant improvements in their quality of life at both the 6 and 12-week marks. And there was a mild increase throughout the study in terms of post-void residual, peaking at the first point at 2 and then declining towards baseline by the 12 weeks time frame down to just over 30 cc's. Overall, relatively safe. As you can see, there were no serious AEs related to either the study drug or the study procedure in the active arm. There was 1 bladder hemorrhage in the placebo arm. And there was a small increased rate of urinary tract infections in the active injection versus placebo, and this is consistent with the change in prior phase 3 and phase 4 studies. The alternative Onabotulinumtoxin injection paradigm, by targeting the peritrigonal and trigone, significantly improved urgent incontinence episodes as well as quality of life, and the incidence of CIC was significantly lower at 2.6% versus a 6.2 in the phase 3 and phase 4 clinical trials. Again, both patients who required CIC were males with a history of BPH. There was no CIC use in any of the female patient population after the first injection. Adverse events from the alternative paradigm were mostly consistent with the standard injection paradigm, and although not a direct comparison, the study suggests that alternative injection paradigm reduces the need for CIC versus the standard paradigm, while maintaining a similar efficacy and improvement in quality of life, although there does appear to be an increase in urinary tract infections. Thank you.
A question from the floor? Yes, please.
Ibu Versi, I want to congratulate you on a great study. Presumably you did this because you think that the afferents are all in the bladder base and trigone region, and that's what you want to hit rather than the detrusor muscle all over, which will impair contractility. Is that
correct? The theory being that the motility starts at the dome and works its way down. This is targeting, again, the afferent area.
So you know botulinum toxin spreads after you put it in. There have been some studies to show that. So why bother with so many injections? Why not just have one trigonal injection? Would that work? And the other question is, in females, as the trigone is intimate with the vagina and very superficial, why not go from below and through the vagina into the trigone and avoid a cystoscopy?
Interesting question. I mean, certainly have to start somewhere. So to go from 20 to 1 might have been a quite a large jump. But I think in future, again, we're looking at alternative injection paradigms, and certainly looking to see if you can minimize to 1 will make sense. Yeah.
Thank you.
Hi, Dick Johnson, Nijmegen, the Netherlands. I was wondering, your last statement says it might be a better injection paradigm compared to potentially the more traditional random or diffuse biopsy scheme. Why did you choose the placebo group as a placebo group and not just the diffuse injection scheme, which would be much more logical and supportive of what your aim was of your study?
Yeah, I mean, I think that certainly would have been a nice option if we could have had 2 active arms. It would have helped recruitment, but this was a corporate decision to go with a placebo arm.
Yeah, because now your most significant statement isn't founded on research, actually. It's more circumstantial compared to other different research done, studies done in other centers. So it might be, it's not supported by your data. That it might be a better treatment paradigm compared to the more regular diffuse injection scheme.
Well, again, the primary goal being to reduce the CIC rate, which I think it certainly showed.
All right, that's true. All right, thank you.
Francesco?
Francisco Cruz from Portugal. My question goes back to the previous question, because in the 20 injection paradigm, the number of patients that were totally dry, if I am not wrong, was above 20%, and now you got 13%. Can you explain that difference? Is the selection of the patients different? They were more severely incontinent, or eventually this paradigm is less effective, and if you want to get, let's say, a higher percentage of patients dry, we should go back to the previous one?
Yeah, I mean, I think, certainly that is, we're looking at 2 different populations. So you need a head-to-head study to truly tell you, is the dry rate comparable? So that's going back to the answer of, it would be nice in the future to have a trial between 20 versus 10 instead of a placebo to be able to answer that question more effectively.
So really the most important thing is the number of patients that were on CIC.
Right, I mean, I think that's a natural barrier to physicians explaining this to patients, and certainly patients choosing this as an option is the risk of CIC. So looking for a paradigm which could open this up to more patients and make practitioners feel more comfortable delivering the care, I think was an important first step.
Okay, thank you so much.